Good evening. My name is Dr. Kathleen Digre, and I'm a distinguished professor of neurology and a professor of ophthalmology. And I'm so excited today to talk about migraine and how it affects vision. And so the question that I've been asked to answer is, why does my vision change with migraine? So, headache is really common, and migraine can be disabling. 70 to 80% of adults suffer from headache sometime in their life, and even up to 38% of children, almost half children, will have a headache. About 10 to 20% of individuals are predisposed genetically to get migraine, and migraine causes more office visits than asthma and diabetes combined. Not only that, but people miss work, lose income, and the cost to society is in the billions. The World Health Organization has put migraine in the top 10 burden of disease for the world. And almost every individual with migraine has visual complaints. 20% will have aura, but everyone with migraine will have a visual complaint. Now, I think it's important that we understand the migraine attack. And the first thing I want you to look at on this slide is prodrome. So prodrome is a time before the migraine attack starts where people can have food cravings, they can have a little neck pain, and then they can get blurry vision, they can get light sensitive, and about 20% of people with migraine will have aura. They will have aura that starts, and we'll talk about what an aura is before the headache comes on. And then once the aura finishes, the headache starts, and that can last 4 to 72 hours. And people have nausea, vomiting, light and sound sensitivity, fuzzy thinking, dizziness. And then after the head pain is gone, there's a postdrome phase where the symptoms can last for a long time, and even visual symptoms can last a long time. So I want you to understand that a migraine attack is more than just the head pain, but it has a prodrome, it can have an aura, it can have a headache, of course, and a postdrome. Now, I'd like to share with you this case of Mike because he has actually an aura. So I'm going to stop sharing that screen, and I'm going to share this screen. And this is Mike, and I hope you can hear this story.
So Mike, before we go, can you get that screen over at Hardware Hanks? And also, you know what? We've got to trim the hedge or it's going to look really horrible by
Look
the
what's
time we get
happening
back.
over here.
I'm trying to think what else. Oh yeah. Can you bring all the storm windows down on the bottom floor so that we can, you don't look too swift. Mike, are you listening to me? You look dazed. You're not getting a migraine, are you? Look. Oh, Mike, we are leaving for Massachusetts tomorrow. You can't get a migraine. I need help to get packed and to get ready and to get these hooligans out of here.
Do I have a migraine again?
You need to go lie down.
What's
What's the matter, Daddy?
Daddy,
Are you sure? Okay.
Do I have a migraine?
Now let's go back to our slideshow, hopefully. So Mike, you saw him. He's 30 years old. He's a teacher. He has a family history of migraine. You could see he was starting to have blurry vision, and he's not sure what's going on. Then he got that spot that went off to the right side. Then the spot starts to go away, and then he gets a throbbing headache. He has light sensitivity, sound sensitivity, nausea. His aura can last up to 40 minutes. Imagine having a visual disturbance last 40 minutes, then a headache, and then he gets nausea, vomiting, and he has to go to bed. So he had that aura that came on, this great big headache. And so this is called migraine with aura. Now, an aura is a neurologic event, and about 90% of these auras are visual. There can be sensory auras where the numbness in the like hand or in the mouth. Sometimes speech can be affected. You might remember that newscaster who started to have garbled sentences in the middle of her newscast. She was getting a migraine with speech and language problems. Those are typical auras. Now you can get a motor aura, but that's called a hemiplegic migraine. We'll talk about a brainstem aura, and retinal migraines are extremely rare. Typical auras develop over a period of time, at least 5 minutes. And as I said, it can go over 40 minutes. And some people can have one aura followed by another aura, followed by another aura, or just two auras, or just one. And the aura can last usually not more than an hour. And most of the time, the symptom is unilateral and sometimes positive. Did you see the flashing light, the zigzag lines, the kind of undulation that he was seeing, and then kind of a brown gray spot in his vision? And then it's usually followed by a headache. The terms people sometimes used to use are ocular migraine, but ocular migraine really doesn't exist. It's migraine with aura. So people have studied, what do patients say they experience? And these are some of the descriptions people have discussed and experienced. Flashes of bright light, foggy, blurred, dim vision, the zigzag. Remember, Mike's was definitely zigzag, jagged lines at the beginning. The scotoma, like Mike had that scotoma where he couldn't really see his kid's face for a little bit. Black dots, flickering lights, heat waves, or like ripples on water, white spots. Hemianopia just means losing half of your vision. Tunnel vision, meaning your vision tunnels in. Curved or circular lines in your vision, colored dots, or a corona phenomenon. This aura was drawn by one of my patients who actually was a resident in family medicine. And you can see he had that kind of zigzaggy, just like Mike, where it was kind of a kaleidoscopic thing that went on for 25 minutes before it went away. So these are descriptions of people's aura, but it develops slowly. It's not like a little flash of light. So I mentioned that some of the auras are cortical, which is the wavy lines, the zigzag lines, and sometimes they can be really complex, like people can have hallucinations like Alice in Wonderland. So Lewis Carroll, who wrote Alice in Wonderland, actually had migraine aura. And we think some of his descriptions of Alice came from his aura. So you can see how Alice has got an elongated neck. And remember, she got really small at one point, then she got really big at one point. And these are what we call Alice in Wonderland effect. Now, other things can cause it, but migraine is one of the causes. I talked to you about the speech problem, the sensory problem. Now, brainstem aura, it used to be called basilar artery migraine. Well, we know that the basilar artery is not constricted. It has nothing really to do with the basilar artery. So now we call it brainstem aura. But these auras can be really weird. Like people can have vertigo followed by a headache, diplopia, dysarthria, ringing in their ears, or hypersensitive sound, or ataxic, or they can even lose consciousness. And then, of course, if they have weakness, it's called a hemiplegic aura. Now, in Utah, where I live, aura is much more common than in people who live at sea level. We found in one of our studies that we had a higher prevalence of aura, even up to 48% of our patients, versus a sea level collaborator of 18%. And altitude is known to increase the likelihood of headache, mountain sickness, and mountain sickness really looks like a migraine. People are light sensitive, they're nauseated, and they have a throbbing headache. And then we have changes in our oxygen and barometric pressure at altitude, and the light is different. And interestingly, even depression and suicide are more common in Utah than people who live at sea level. So why would that be? Well, the brain of a person with migraine is very sensitive. They do have an altered neurophysiology where their visual system, their hearing system, their smell system is almost ramped up so that they are more sensitive than any normal person. And we think that that has to do with their sensitive brain. The aura, as we know it, is caused by what we call cortical spreading depression. And here is a fMR that's showing us that something is happening in the occipital lobe in this person who's having an aura with their migraine. And then we get this somewhat of a depression that happens as well. And sometimes we even see a change in the blood vessels. So now I'm going to show you an aura in a laboratory animal, and you can induce an aura in the cortical spreading depression in a laboratory animal by using potassium chloride. And this came from Casey Brennan here at the University of Utah and the Andy Charles Lab. But could you see that wave going across that cortex of the brain? And then look at the little blood vessels, how they kind of change, they kind of constrict, and then they kind of dilate. So this is a spreading depression. So there's a physiologic thing happening in an aura. So it's not, people don't make this stuff up. This really happens in the brain. And we can prevent auras. We can't really treat an aura when people have it, but we can prevent them. If people have a lot of auras, magnesium is something that can prevent aura. Baby aspirin sometimes prevents aura. And then many of our medications that we use for migraine prevention can prevent migraine with aura, like topiramate, verapamil, amitriptyline, the CGRP monoclonal antibodies, Gepants, and then many others that are used as migraine preventatives. Acutely, you cannot treat the aura with headache medications. You treat the headache, but you can't treat the aura. So to treat the headache, of course, we have triptans, we have Gepants, we have ditans, midrin ergotamine, and often we have to treat the nausea. Now, people with migraine often have other visual symptoms, like they can get a blurred vision during their attack or prodrome, and that is not an aura. That's just blurry vision that occurs in the prodrome or during the headache, and that is common. 25 to 50% of people say they have blurred vision during their migraine. And some people have some persistent positive phenomenon off and on. Now, I'm going to talk about continuous persistent positive phenomenon like visual snow. But some people have other things like stripe-induced discomfort. So they look at a Venetian blind and it just drives them crazy because of the stripe-induced discomfort. Also, flickering lights for people with migraine. Oh my goodness, people don't like those and it can trigger a migraine. And then I'm going to talk about visual snow and photophobia. But just look at all the little persistent symptoms that people can report. And most of these people have migraine. Little bubbles or circles or comets. Some of these can be migraine, aura, meaning that they have to start little and grow and grow and grow, like we talked about, like an aura. But sometimes you can just have a few flashes here and there. You could have a little squiggle once in a while, a little flicker in your peripheral vision once in a while, just because the visual system is so sensitive. So here's another patient. This is a 17-year-old, and he was sent to me for persistent aura, like he was having aura all the time. That's what the referring provider said to me. Now, I got the history. He did have a family history of migraine, which most people do, and a typical migraine without aura, and occasionally they have a migraine with an aura about every 3 to 6 months. He's a great student, but he said, you know what? Every time I concentrate on my books and stuff, I see kind of silvery lines. And then I look at the sky and sometimes I see floaters in the sky, or if I go skiing on the snow, I see my floaters. And then I've got this greeny vision, and I've had that since as long as I can remember. So the question to me was, is this persistent aura, or was it something else? And so he had silvery lines that were always present, floating and squiggly lines, and grainy vision. and he can see through it. So his vision was perfect. He had 20/20 vision. He had perfect vision. His fields were full. He had normal retinas. He had normal optic nerves. He had a normal neuro exam. So I showed him these pictures. These pictures are of phenomenon that come with what we call visual snow. First, this is the grainy vision that he was experiencing. So imagine looking at it, at what you're looking at it, and it looks almost a little fuzzy, like an old analog television set, staticky. And then when he looked at the sky, he saw these floaters. See how you can see these little floaters in the blue sky? And then if sometimes he'd see little sparkling dots of light that would be in the blue sky. And then he had there are two forms of palinopsia. One form is if you see an object moving, you see the trailing edge. So you can see in this picture of the hand holding the pen, you can see a trailing off to the side. Or the other form of palinopsia is you look at an object and then you look away and you see the object still there. So these are two forms. So I said, okay, which ones of these can you see? And he said, those three: grainy vision, floaters, and little silvery dots that he saw in the sky. So he had visual snow. And we think that you have to have this at least 3 months. People have other symptoms that come with it, that palinopsia, either the trailing image or the image duplicating itself. Sometimes enhanced entoptic phenomenon, which is the floaters. Self-light of the eye is where you close your eyes and you may see swirls of purple clouds or something like that. Photopsias are little white dots. Photophobia is light sensitivity, and nyctalopia is sometimes trouble seeing at night. And sometimes people have tinnitus, where they get a little ringing in their ears all the time. And these are not typical of migraine aura. You just saw what a migraine aura is like. And these symptoms were not explained by another etiology. So visual snow is seen in boys and girls, women and men. Most people have a history of underlying migraine, up to 60%, but headache, some kind of headache, is present in almost 90% of people. About 20% of people with visual snow can have some anxiety and depression. And about a quarter say, I've had a snowy vision as long as I can remember. And it's often continuous from the beginning. And as I said, there's a high prevalence of tinnitus or ringing in the ears. And there are changes in the brain. If you do PET studies, you can see changes in the brain in people who have visual snow. Now, if visual snow comes on later in life, you have to look for a secondary cause. Sometimes there's something wrong in the vision, the retina. Sometimes there can be trauma that invokes visual snow or stroke. So that's a secondary cause, and it's very important that an ophthalmologist see the patient as well as a neurologist to figure out what the cause is, because that's a secondary cause. So how do we treat visual snow? Most of the time, we just reassure people, you're not crazy. This is visual snow, and it is one of these things that happens in the brains of people who are kind of extra sensitive in their visual system. Medications don't always work, but we do try medications sometimes, like lamotrigine, nortriptyline, carbamazepine, sertraline, and sometimes filters in our glasses can work. So spectacles, FL41 tinted spectacles, can also be helpful for some people. Okay, I'm going to switch gears to another visual phenomenon with migraine. So this is a 35-year-old woman. She has severe light sensitivity since a minor motor vehicle accident about 6 months ago. She's not leaving her house. She has a previous history of migraine. She wears sunglasses all the time, and her eye exam and neuro exam were just normal. So photophobia, which is kind of a misnomer. Photophobia means fear of light, but photophobia means that light is so intense, it's uncomfortable. 80 to 90% of people with migraine have this symptom with their migraine. And it's one of the major migraine criteria. The 3 things that make it a migraine are light sensitivity, disability from the headache, nausea. And if you have 2 out of the 3, it's migraine. But photophobia is so common. It's the most bothersome symptom in migraine. That's what patients tell us. And if a person is photophobic all the time, migraine is the most likely diagnosis. And chronic photophobia, if somebody has photophobia all the time, they have intermittent migraines, but they're light sensitive all the time, there's a relative increase in depression and anxiety in those individuals. It's part of the anatomic pathway of photophobia. And we think that the posterior thalamus and the trigeminal system are involved. And a very interesting cell called the intrinsically photosensitive retinal ganglion cells are involved in this process. Now, photophobia can be caused by problems in the eye, like inflammation, corneal abrasion, iritis, blepharitis, dry eyes, uveitis, the other problems that cause retinal problems like retinitis pigmentosa. People have photophobia with that. And then people who have brain problems like meningitis, pituitary tumors, blepharospasm can be associated with photophobia. And then there's other psychiatric conditions that can have photophobia. There's other medical conditions, and there are even medications that have been known to cause photophobia. Traumatic brain injury is really a common cause of photophobia. Do you need to have vision to have light sensitivity? And the answer is no. So we did a study where we had patients who were legally blind, like 14, they could only see light. And those people, when they had light shined on them in the middle of a migraine, were light sensitive during that period of time. So you don't need vision. So then we have to go to this intrinsically photosensitive retinal ganglion cells. And these are old cells. They live in the retina. So if you look at this picture of the eyeball, they live in the retina, and they go to the suprachiasmatic nucleus and the hypothalamus. So they help us with circadian rhythm. So they help us sleep, they help us wake up, and they're non-visual photoreceptors. So if you took out the rods and cones but left those cells in, you would still have some light perception. The peak wavelength of these cells is blue at dawn and dusk. And when they do studies of animals that have these melanopsin cells and then they destroy the rods and cones, those animals are still light sensitive. But if the animals don't have the melanopsin cells or the intrinsically photosensitive retinal ganglion cells, they're not light sensitive, even if they have vision. The discomfort comes from the trigeminal system, and the trigeminal system is the system that feeds pain to the head. And this system not only feeds our head, but also the base of our skull and around our skull. And in fact, if you stimulate the coverings of the skull, the dura, around the skull, you can have pain around the eye and in the head. And these cells do locate with that trigeminal system, and that's been shown by this paper. Now, is there an emotional component to photophobia? And the answer is yes. There's an increased prevalence of depression and anxiety in patients who have migraine and interictal photophobia. And what this graph is just showing us is this is somebody who has chronic photophobia, and this is a person who has migraine but doesn't have chronic photophobia with their migraine. And this is somebody who doesn't have migraine at all. And you can see their photophobia score is really high, their depression score is really high, and their anxiety score is really high. And what's interesting is that in animal studies, they've been able to show that the limbic system, our emotional center, is all tied up in photophobia as well. So it's part of the brain disorder. How do we treat photophobia? Well, some people, if you just tell people why they're light sensitive, that's okay. If they've got an inflamed eye, then we dilate the inflamed eye and we treat the inflammation. Most people have to come out of dark adaptation, because if you go to a movie, for example, and you sit in the dark all day, you're going to be light sensitive even if you're a normal person without any migraine at all. We have to treat the migraine. Some investigators have found that green light has the least effect on photophobia. So, for example, I use green light when I'm examining patients who are really light sensitive. And some people believe that the green light can actually help their migraine too. And then tinted lenses like FL41 and certain other contact lenses, red contact lenses that block these blue wavelengths can sometimes be helpful. This is FL41 tint. It blocks this melanopsin pathway, the 480 nanometer pathway. Interestingly, it was first used in orphanages in England by a very smart group of scientists, and they reduced migraine in half in kids by just wearing these glasses. So we have been studying this in our patients with migraine, blepharospasm, and other causes of photophobia, and this is really helpful for many people. Not everybody, but for many people. Other treatments for light sensitivity or photophobia, we often treat dry eyes. It's the most common accompaniment to photophobia and chronic migraine. So talk to your doctor if you have chronic photophobia and migraine. Talk to them about whether you do also have dry eyes, because you can treat that. Botulinum toxin has been very helpful for individuals. Anecdotally, anticonvulsants like gabapentin have been helpful. Anecdotally, we found that CGRP monoclonal antibodies and GPANTs help with the most bothersome symptom. It's been shown in many randomized controlled studies to help with photophobia. Always partner with a neurologist that knows how to treat migraine, and also if there is comorbid depression and anxiety, treat that as well. I also recommend partnering with an ophthalmologist to maximally treat dry eyes if that's present. Rarely do we have to partner with a pain clinic to consider a sympathetic block. Some resources for you besides our wonderful headache school that I hope you'll listen to all of our lectures in our headache school is the American Migraine Foundation, and that's americanmigrainefoundation.org. And interestingly, they have beautiful wonderful handouts of demystifying migraine with aura, understanding migraine with aura. And some people get migraine aura without a headache. And interestingly, as people get older, you can have more aura and less headache. And if you have frequent aura, you should really see a neurologist or a neuro-ophthalmologist to talk about what could be causing that. And then they have a wonderful handout also on photophobia or light sensitivity with migraine. So I hope at the end of this short tutorial that you have found that migraine is more than a headache, that it affects our visual system in almost everybody who has migraine. Proper diagnosis of the cause of any visual complaint in migraine is essential. Education is necessary. And I hope I've also conveyed to you that treatment is possible, that we have so many more treatments now for many of the symptoms that we have, and more research is clearly needed to help us understand migraine aura, migraine itself, photophobia, visual snow, and all these other amazingly interesting light and visual symptoms. So with that, I'm going to stop sharing. And generally what we do is